A very good morning to everyone. Today's topic is on a glaucoma, mastering the meds, a deep dive into glaucoma, pharmacotherapy. The first speaker is Dr. Manju. She is working as a glaucoma and phaco surgeon at Arya Eye Care. Over to you, Anju. Choosing the first line therapy, one size fits all.
Thank you, Dr. Saumya, for this opportunity. Choosing the first line therapy in glaucoma, what does one size fits all? So, how do we choose the first line therapy, or how do you decide which drug to be given as a first line therapy? One thing and most important thing is the target IOP which you choose for that patient according to the disease severity and age of the patient and considering various factors. And next is the systemic and ocular comorbidities of the patient, and what is the lifestyle of the patient, how he will be able to adhere to the medical therapy you are giving, cost and accessibility of the medication, potential side effects and tolerability. These are the factors which should be considered when you decide on the first line medication, first line therapy for the patient. Over a few of the medications, prostaglandin analog, adrenergic beta adrenergic blockers, alpha agonists, carbonic anhydrase inhibitors, and rock kinase inhibitors. If some cases we can give. First thing will be the prostaglandin analog. This is Laszlo Bito who invented prostaglandin analogs. And this was the journey of the prostaglandin analog, which first one to be invented is the latanoprost in 1995, and next is bimatoprost, tauprost, tafluprost, and the last one is a latanoprostine bunod in 2020. And these are some studies on prostaglandin analog. This one is a landmark study which is the first major multicentral trial establishing latanoprost. This established latanoprost as a safe and effective once daily prostaglandin analog, and leading to the widespread, and it has led to the widespread adoption of it as a first line medical therapy. Next is a comparison of once or twice daily bimatoprost with twice daily timolol in patients with elevated IOP, and this was James et al. And it concluded that bimatoprost 0.3% one night, not the twice daily dosage, but one night dosage produced statistically greater IOP lowering than timolol. It had more IOP lowering than timolol and than the twice daily dosage. So, bimatoprost is one of the most established as one night therapy, and it's the most effective single agent topical prostaglandin analog. So, in which all conditions do we usually choose prostaglandin analog as a first line therapy? One and foremost thing is a normal tension glaucoma and POAG, primary open angle glaucoma, OST, and secondary glaucomas without inflammation. So, inflammatory conditions, we don't usually choose prostaglandin analog, and it's usually avoided in NVG due to its pro-inflammatory characteristics, uveitic glaucoma because of the same reason, and it's avoided in unilateral glaucomas because it can produce a prostaglandin associated periorbitopathy or periocular changes. Because of that, it's avoided in unilateral glaucoma, it's avoided in children and young adults because of the same reason, and it's avoided in pregnancy because it can precipitate early delivery. And potential side effects are conjunctival hyperemia, which can be transient, increased pigmentation of the iris, eyelash changes like increased length, thickness, number of the eyelashes, and there can be periorbital skin pigmentation and darkening of the eyelid or surrounding area, and can also lead to the prostaglandin associated periorbitopathy. This is one of the patient who was using prostaglandin analog unilaterally. You can see the deepening of the upper eyelid sulcus, there is enophthalmos, and compared to this side there is a little bit of a periocular hyperpigmentation, and here there is fat and there is a fat atrophy. So, if you give prostaglandin analog unilaterally, there is a chance of an iatrogenic dysmorphism if given unilaterally. So, this should be explained to the patient if you are choosing to give the patient unilateral prostaglandin analogs. And now there are advancements where you can have ocular inserts which release prostaglandin analogs on a daily basis, and it can be left in the eye for 3 months to 6 months. There is Durista and other periocular and ocular inserts of containing prostaglandin analogs. This is a recent invention. Coming to the beta blocker Timolol, it's given in various concentrations. It's a non-selective beta-adrenergic blocker. It decreases IOP by reducing aqueous humor production. Once or twice daily dosing is usually preferred. Can be used alone, or one thing is that when it is started as a first-line therapy, later it can be combined with other anti-glaucoma medication, and it's cost-effective and widely acceptable. And this is a study by Zimmerman et al. And it is a double-mass placebo-controlled trial which was done long back in 1977, and it concluded that twice daily dosage significantly reduced intraocular pressure without major or ocular or systemic side effects, establishing it as a first-line effective non-myotic anti-glaucoma therapy. It's usually preferred in POAG, OST, any kind of secondary glaucomas, and can be used in post-op IOP rise and even used in unilateral glaucomas. It's usually avoided in NTG because of this vasoconstrictive effect, elderly patients because it can cause bradycardia, bronchial asthma, COPD, and can also cause sinus bradycardia or AV block. It's avoided in lactating women because it's precipitated in the breast milk and can be transferred to the child. Avoided in children because of this bradycardia effect, and it is avoided in diabetic and thyrotoxicosis because it can mimic signs of hypothyroidism and glycemia. And which PGA versus these are the two drugs which is usually preferred, prostaglandin analog or timolol. Main thing is that cost constraint. If the patient has financial constraint, timolol is preferred. Otherwise, prostaglandin analog is the first line therapy. But timolol is something that is effective, affordable, and dependable if cost is an issue for the patient. And third one is a brimonidine. It's used on if prostaglandin analogs and beta blockers are contraindicated. It acts on the alpha-2 receptor of the ciliary and suppress aqueous formation. It can also increase UV scleral outflow. It enhances drainage to the UV scleral pathway. There is a rapid onset of action, so because of that, it can be used as an acute control, like in the case of a post-YAG PI. It has a little bit of a neuroprotective action, and it has addictive effect over other agents. So side effects is follicular conjunctivitis, dry mouth, and CNS suppression. And the drug of choice is if prostaglandin analog and timolol is contraindicated, unilateral glaucoma in a bronchial asthma patient, NTG, post-YAG IOP rise is avoided in children, drivers, and in allergy. And next is a dorzolamide, which is safe for patients who can't tolerate beta blockers. And side effects will be like ocular burning, stinging, bitter taste, superficial punctate keratitis, allergy, or hypersensitivity reaction. Usually, drug of choice if PG and timolol is contraindicated, unilateral glaucoma in bronchial asthma patient, NTG, and children, and avoided in compromised cornea. That is one thing, and should be avoided in early pregnancy because of this teratogenic effect and allergy if there is allergy. ROCK kinase inhibitors usually preferred as a first line therapy if there is an elevated episcleral venous pressure and there is little bit of a corneal edema. There are I will skip this, and take home messages are prostaglandin analogs remain the first line of choice in most of the patients. Timolol is a cost effective alternative option. Carbonic anhydrase inhibitors, alpha agonist, and ROCK kinase inhibitors are valuable other alternatives. You should always, whenever you start a first line therapy, you should always reassess IOP and see for the side effects 4 to 6 weeks after initiation. Individualized therapy based on systemic and ocular comorbidities is important. So there is nothing like one side fits all. Thank you.
Thank you, Manju, for the wonderful talk. We will have the discussion at last. I would like to invite Dr. Bindu S. Ajit. Madam is a senior and a head of Department of Glaucoma and Cataract at Comtrust, Calicut. Over to you, Madam.
Good morning, all. We'll go to the topic of fixed drug combination. Now, what do you mean by fixed drug combination? It's defined as a formulation that contains two or more active pharmacological ingredients combined in a single dosage to form a fixed ratio intended for simultaneous administration to achieve specific therapeutic goal. Now, why do we need this fixed drug combination? As we all know, we have issues with the multiple medications that we start for the glaucoma patients. that lead to the poor adherence to the patient, and definitely our patients are on the older age group and they are confused over the regimens, and there is an increased risk of missed doses and higher cumulative cost. And then definitely the most important now is the OSD, and so the preservative exposure becomes a major concern. Now, why the FDC has advantages over the monotherapy? As the number of drugs are instilled are less in a fixed drug combination, the washout effect is not happening there. The local tolerability is more. Convenience of administration is definitely there. Therefore, the compliance is increased and exposure to preservative is less. As we all know, long-term use of topical medication comes with its own complications of hyperemia, tear film instability, stinging, burning sensation, and dry. And all this is mostly attributed to the preservative exposure. And when you multiply the drops, like I keep on adding glaucoma drops, especially that is required for the long-term therapy, you are adding more and more preservative in each bottle of the drop. So fixed drug combination decreases the ocular exposure to the preservatives. So when you want to join two drugs, what are the things that we take into consideration is it should be complementary mechanism of action which enhances the overall therapeutic effect, that is pharmacodynamic synergy, and for pharmacokinetic matching, you should not be combining two with an opposite action. So now we'll come to the advantages of the fixed drug combination. Definitely it is to improve the adherence and complications because of the fewer bottle and fewer doses. That is what the studies says. And definitely enhanced therapeutic efficiency because of the complementary mechanism of action. It also has an additive effect and reduce the risk of washout, because when you put one drop and immediately put another drop, it has a washout effect also. Economic and quality of life benefits: fewer prescription refills, lesser pharmacy cost and travel burden. That leads to the improved patient satisfaction and reduced treatment fatigue. Now, what are the limitations and challenges of the fixed drug combination? You lose the dosing flexibility. Single ratio formulation and individualized dose adjustment not possible. Especially when you have a tendency to start a fixed combination, you don't know which of the drug has caused the side effect, or which is effective and which is not effective. That is the confusion that we have when you start with the fixed drug combination. Pharmacologically and formulation challenges are there. Chemical incompatibility. This we have to take into consideration when we are making a fixed drug combination. Adverse effects masking the compliance misinterpretation. Yes, we don't know which of the drug is causing the adverse effect. Patient selection and clinical caution. Now we have especially non-glaucoma patient doctors, they have a tendency to start the combinations first. So even in a mild to moderate disease or their first line of choice, there is a tendency for starting a fixed line combination, which should be avoided. Like, when only one drug could be enough, we tend to have a combination drug started, which is actually burdening the patient without knowing the effect of single drug. Now coming to the common FDCs in glaucoma, as the most common is the beta blocker and prostaglandin, because it has a combination effect. It combines reduce aqueous production and increase uvoscleral outflow, and the advantage of once daily dosage. And its long-term studies have also proved that it has got a beneficial effect. Beta blockers and carbonic anhydrase inhibitors, another combination that is available, typically dosed twice daily, and beta blocker and alpha agonist, both having a complementary effect. And the other is the alpha agonist and the carbonic anhydrase inhibitors. Now, we do have clinical evidence comparing the studies of fixed drug combinations, studying the efficacy, safety and tolerability, adherence and quality of life, and economic impact. So these are some of the studies which shows that IOP reduction of more than 30% from baseline was achieved in a fixed combination of latanoprost and timolol. And there are other studies which also proves the combination therapy. Now, these combinations therapy are also intended to see the 24-hour IOP control, which is more because that is the one which is causing progression of glaucoma as the proven things. So, this is also taken into consideration when fixed drug combinations are used. So, fixed drug combination that provides round-the-clock suppression are clinically preferable for progressive diseases too. Now, what are the gaps? We don't have the fixed drugs which have studied the effect on visual field progression. And now, what are the recent advances and future perspectives of the fixed drug combinations? Yes, fixed drug combination has improved the compliance, but further innovation is needed. Now, we also have the triple fixed drug combination with greater IOP reduction, single bottle convenience. And now we are into novel drug delivery systems like the previous speakers told, because it needs a sustained release FDC, hydrogel inserts, punctal plugs, biodegradable implants, subconjunctival and intracameral depots are in the process of coming out, which eliminates daily dosage, improves adherence and reduces the surface toxicity. And the other future perspective is the preservative-free fixed combinations and the nano formulations FDs, which are also to improve the compliance and decrease the side effects of the glaucoma drops. The next generations are the Rho kinase inhibitors and the prostaglandin analogs, and triple FDCs is already there, and fixed combinations with novel targets is on the studies. Now, the other, like all the future prospects are the linking with the AIs, enabling patients for more increasing the compliance, and also that is artificial intelligence into the dropping systems too is what is future now. These are all futures. So, the for practice, it is FDC is the best choice when more than 2 agents are needed and titrated flexibility not critical. Always verify systemic contraindication of both the drugs. Prioritize ocular surface health and simplify, educate and monitor to reinforce adherence at each visit. Thank you.
Thank you, Bindu, for that excellent talk. Now I invite Dr. Shweta. She's working as a glaucoma consultant in Jyoti's Eye Care, Kannur. She will be talking on when medicines fail, identifying treatment non-responders. Over to you, Shweta.
Thank you, Dr. Soumya, for giving me this opportunity. And thank you, Dr. Manju, for that introduction. So my topic for today is when drops don't drop the IOP. This is something very practical that we usually see in our day-to-day practice. Have you ever wondered why some patients just don't respond at all? The IOP is unchanged or it's increasing and something isn't adding up. So first, to know we need to know where each drop works to know why it may not work. So who is a non-responder? Any patient who has a difference of less than 15 to 20% of IOP drop between pre-treatment and post-treatment is considered to be a non-responder. So we have to find why the IOP didn't drop. So this is a case scenario of a 64-year-old male who had a moderate POAG and his baseline IOP was 26 millimeters of mercury with a CCT of 545. He was started on a prostaglandin analog. And 3 weeks follow-up, his IOP has dropped to 24 and 23, which is just 7 to 8%. We expect at least 20% drop in 3 weeks follow-up. The patient was confident about the usage and we had asked him to demonstrate in the clinic and he had a good technique and there was no steroid or ocular surface issue. So this is the first case scenario. And second case scenario is a 72-year-old male who had an early stage of POAG with CCT of 560 and similar IOP drop. And patient says he used the drops properly, but in the clinic, poor technique was observed. So these are the two common scenarios which we see in non-responders. So non-responders can be true non-responders and it can be apparent non-responders. What do they mean? So generally we have some issues in the pharmacological of the drug drug can have drug resistance, tachyphylaxis, or it can have ocular barriers, poor penetration, especially when we have the carbonic anhydrase inhibitor. They cannot penetrate through the cornea in some cases. Any severe trabecular meshwork dysfunction can affect the prostaglandin and uveoscleral outflow. And the patient can be non-adherent and poor installation technique can be there. And measurement errors, the tonometer which we are using, the CCT can have effect. And disease biology like NTG, normal tension glaucoma, and vascular factors, these all can affect the why medications fail. So here top 3 are considered to be true non-responders, and bottom 2 the apparent. So in true non-responder, there is no pharmacological effect. It can be NTG vascular component, receptor issues, and severe TM dysfunction. And there is something called a masked non-responder. Here there can be additional steroid which the patient is using, some Ayurvedic preparations, some other local medicines, or some skin ointments or inhalers, which we do not ask always. And that can be a result of raised IOP. And there can be an angle closure component. It's always not that in a slit lamp you don't see a shallow AC, doesn't mean that is an open angle. Always do a gonioscopy for all the patient. And he can be on some other systemic medication like beta blockers if he's using oral. The beta blocker topical may not affect. And IOP fluctuation is one important thing which we always miss. There can be a diurnal fluctuation which we may not see, and that can be a reason for not response. And apparent non-responder is because of the patient issue, techniques, timing, missed doses, and the measurement errors. So we have a drug check timeline that prostaglandin takes at least 4 to 6 weeks for its peak effect, beta blockers 2 to 4, alpha agonists 2 to 3, and carbonic anhydrase inhibitors 1 to 2 weeks. So generally when patient come to you, first thing you do, diagnose, stage the disease with fundus photovisual fields OCT, and then you have to find the baseline IOP, see the fluctuations, diurnal curve, and form a baseline IOP, then fix a target IOP based on the staging. It can be percentage drop, or it can be according to the mild, moderate, severe disease. Then you call back the patient after starting him on treatment after 2 to 3 weeks according to the medication used. And if the target IOP is achieved, you just continue the AGM. But what to do if you do not have it is not achieved? So it can be, when it is not achieved, it can be partial lowering or it can be total complete non-response. Partial lowering is something you can have at least 20% of drop, but it has not reached the target IOP. And if still we have time for the drug maximum action, nothing wrong in waiting if the patient is not an advanced case. And if there is no change, you ask the patient how you apply the drop. If the patient is applying the drop and if he's an elderly, definitely there is chance that the technique is wrong or the drop is missed. The second thing, you look for a detailed history of any steroid. Third, you check the IOP reduction. The most common cause of non-compliance is difficulty in installation, forgetfulness, difficult schedule, cost, and mistrust in the doctor. So these are all practical things which we see. We feel that the patients are using the drug, but generally in our population at least 50% of the people are non-adherent and non-compliant. So check if the baseline IOP is correct. Is the patient using it properly? Is the drug given enough time? Is there something masking the receptor? Is the percentage drop less than 15 to 20%, and is the nerve still progressing? You see all this and you know that it's a true non-responder. Then you can change the drops. So generally you ask the patient how you instill the drop. Look for any signs of, like if there is a hyperemia, we know that the patient has used it. Any side effects of the drug you can see. Ask for the bottle, like you have prescribed, how many bottles you have used. So you look at the bottle level, how much has come down. Ask the exact timing of the last dose. They would have missed last, like previous night or morning. And when there is no partial lowering, you can always either change or add the drops. So generally in partial lowering, what we do is, we know that particular drop is acting. So generally we add another class of medication. Or if it's a generic one, you can change even to the branded ones. And if nothing's working, you can go for SLT, trabeculectomy, or KDB. SLT is a very good option. It works best in virgin eyes, But even with single medication, if you want to stop that medication, SLT really works in open angle glaucomas. And if there is no change, you have to change. It can be class switching within the prostaglandin, or you can change to a different class, or you go with the mixed procedure or SLT, and if required, you can do the trabeculectomy. So this cycle continues till you get a maximum tolerable medical therapy. And one thing which I wanted to tell is, as madam said, rightly said, now we have the triple drug combination. We see lots of patients coming with triple drug combination which have started for the first time. We never know whether each drop is acting or not. It doesn't mean that all prostaglandins will act in all the eyes. Beta blockers, same with that. So you have to make sure that each drop is acting. Only then you ask them to continue it for the lifetime. So before starting the combination therapy, you can always call them back. If they are not high risk of glaucoma, any further loss, you can call them back early. Even if it is above 30, 35, you put them on an oral astazolamide, then put one single medication, call them back early. If you know it's acting, you can add another drop, and later on you can change it to a fixed drug combination. Make sure all the individual drops are effective. So vision loss is irreversible, but non-responders doesn't have to be. We need to be a little more patient in taking proper history and examination of the patient. Thank you.
Thank you, Dr. Shweta, for that excellent talk. Now I invite Dr. Soumya PP, who is working as glaucoma consultant in Contrast Eye Hospital, Talasheri. She will be talking on Beyond Drops, the role of neuroprotection in glaucoma. Over to you, Dr. Soumya.
Thank you, Manju. By definition, as you all know, glaucoma is a progressive neuropathy characterized by retinal ganglion cell loss and the visual field defects. So the current standard, IOP lowering is the only proven modifiable risk factor but fails in many cases to halt the progression. The need for neuroprotection targeting the IOP independent neurodegenerative mechanism offers a complementary pathway to preserve the vision. So what is neuroprotection? It is about going beyond the lowering the intraocular pressure to directly protecting the retinal ganglion cells and the optic nerve from damage. Why neuroprotection matters? IOP is the only proven modifiable risk factor, but many patients still progress despite good IOP control. Glaucoma is increasingly seen in neurodegenerative diseases similar in mechanisms to Alzheimer's, Parkinsonism, etc. The neuroprotection aims to preserve RGCs, their axons, synapse, connections independent of the IOP. So only when we understand the cause of the retina and the optic nerve degeneration, we can tackle it and get to stop it. What is the cause? The axonal loss, which causes the RGC cell death. We have to understand there is a window period by that time. Here comes the action of the neuroprotection. So what is the mechanism of neurodegenerative in glaucoma? That is the mechanical stress from elevated IOP damaging the axons at the lamina cribrosa, and the excitotoxicity, that is excessive glutamate, NMDA receptor overactivity, and which causes later apoptosis. And there may be any oxidative stress mechanism that damages the mitochondria and the axonal transport as well. There may be some neuroinflammation which activated the microglia releasing the toxic cytokines, and there may be loss of neurotrophic support also. So these are the mechanisms. So what are the neuroprotective strategies? We have to consider all this. That is NMDA receptor antagonists. Memantin shows a preclinical promise. I will come into it later. Antioxidants and mitochondrial protectants, neurotrophic factors, calcium channel blockers as well. The stem cells and the gene therapy approaches, and the existing IOP lowering drugs which is neuroprotective side effects, that is brimonidine, which shows to protect RGCs beyond the pressure control. Coming to the NMDA receptor antagonists, there are nanoparticles with topical delivery memantin. These studies have been going on, and a notable study developed memantin loaded PLGA PET nanoparticles and has been used as eye drops with good safety and tolerability. And the next one is the alpha adrenergic modulation of NMDA receptors, that is brimonidine. As I told you earlier, it was found to protect the RGCs by modulating the NMDA receptor activity, not just via the lowering the IOP. Coming to the DOC3 DOCK3 mediated NMDA receptor internalization. Researchers identified DOCK3, a guanine exchange factor which binds the guanine N2B subunit to the NMDA receptor in retina and preserving the RGC's survival. Then comes to the classic and combined NMDA antagonist model as well. That is, study is going on in this. Coming to the next one, that is antioxidants in the glaucoma management. The aim of the antioxidants is to neutralize the ROCs, protect mitochondrial function and preserve the RGCs. Another method. Most common antioxidants, vitamin E, vitamin C, coenzyme Q10, which I have been using also, alpha lipoic acid, polyphenols and N-acetylcysteine as well. Then mitochondrial protection strategy, that is coenzyme Q10 improves ATP production, stabilizes mitochondrial membranes. Then creatinine supplements, mitochondrial targeting antioxidants. Then comes the gene therapy, that is going on, studies are going on this, and the lifestyle factors, that is diet rich antioxidants, that is berry leaves, leafy vegetables, omega-3 fatty acids as well, and the regular aerobic exercise to enhance the mitochondrial biogenesis. The recent research highlights and the clinical trials show coenzyme Q10 as well as vitamin E eye drops provide visual field stability in open angle glaucoma, and mitochondrial Q demonstrated significant RGC survival benefits in animal models of optic nerve injury. These are the neurotrophic factors I have been talking about. BDNF, the CNTF, NGF, that is giant cell derived neurotrophic factors as well, fibroblast, growth factor, all these acts and helps in the neurodegeneration. There are direct neurotrophin delivery, there is gene therapy, small molecule receptor antagonists, stem cell based therapy, and there may be combination therapy of all this. The direct neurotrophin delivery, that is intravitreal injections of all these BDNF, CNTF or NGF is also going on, and the gene therapy, that is viral vector markers like AAV and lentivirus delivering all these factors, allowing sustained local production. And the small molecule TRK receptor antagonists which mimic neurotrophic action without protein instability issues, and cell-based delivery, and a combination mechanism of therapies, that is neurotrophin therapy along with the IOP lowering and along with the mitochondrial production. These are the recent research findings, that is 2023 to 25, that is CNTF implants encapsulated cell technology showed sustained RGC preservation in human trials, and AAV2 BDNF gene therapy as well, and the mimatidine, and a combination of BDNF and coenzyme Q10. There comes another factor, that is calcium channel blockers. The mechanism of action glaucoma is neuroprotection, vasodilatation as well as IOP effects. The neuroprotection, it prevents calcium overload in the RGCs, inhibits calcium mediated excitotoxicity causing excessive glutamate release, and reduces oxidative stress and mitochondrial damage. It causes vasodilatation, relaxation of the blood vessels, and IOP effects has been also seen. In the normal tension glaucoma patients may benefit most as vascular dysregulation plays a role in this case. Targets for the gene therapy in the glaucoma. Why do we have to use a gene therapy? It helps in to reduce the IOP, neuroprotection, neuroregeneration and mitochondrial support. These are the other recent advances that I have been telling. So coming to the emerging innovation approaches, these Rho kinase inhibitors, exocytotomes, nanoparticles, gene and step therapies also have been helpful. The challenges in translation to the clinical practice. There is a mismatch in the preclinical vs clinical outcomes for all these studies, and the studies are still going on. Lack of strong level 1 evidences and delivery limitation and safety concerns are also there. So the future direction is a combination of IOP lowering drugs with targeted neuroprotective strategy tailored to the individual glaucoma mechanisms. Is a designing better clinical trials has to be done, and advancing targeted delivery system. Then that's nano carriers and even gene vectors for safe and sustained neuroprotection. Despite huge research efforts, no neuroprotection drug is yet FDA approved specifically for glaucoma. So my summary and take home point is that glaucoma is a multifactorial neurodegenerative disease requiring more than IOP management. Neuroprotection focuses on salvaging the RGCs via intervention independent of the pressure control. A broad range of agents from pharmacological and neurotrophic to nanotechnological and genetic has been used. Thank you.
Thank you, Dr. Soumya, for that wonderful talk. Now I invite Dr. Kavya Subramanian, who is working in Aravind Eye Hospital, Tirunelveli. She will be talking on New Horizons, investigational drugs on the radar. Over to you, Dr. Kavya.
Good morning, all. Thank you for the nice introduction, and thank you, Dr. Soumya, for giving me this opportunity. I will be presenting on the newer investigational drugs on the glaucoma management. As we all know, currently we are focusing on the IOP reduction because that is the only modifiable risk factor which prevents the progression of optic neuropathy. From the cholinergic agonist, now we have reached and we have currently using the ROC kinase inhibitors, and which was introduced in the field in 2017. So coming to the proper topic, so why we need new drugs? Because only IOP reduction will not help us to control the glaucoma progression. We need to protect the optic nerve, so we need neuroprotective agents. And many our conventional glaucoma medications are having many systemic, which are contraindicated in systemic diseases like asthma and cardiac disease. So we need some drugs which can be used in these conditions, and many of the side effects are due to preservatives, so we need preservative-free drugs, and new drug delivery systems are there. So we will be seeing these preclinical trials, the drugs undergoing preclinical trials and ongoing clinical trials and in clinical use one by one. So first I will be stressing on the ROC kinase inhibitors because we are currently started practicing on this. So there are three agents, ripasudil, natasudil and fasudil. Fasudil is currently undergoing clinical trials. Ripasudil and natasudil has already came in the field. Their mechanism of action are three. They will increase the trabecular meshwork. They will remodels the trabecular meshwork and increases the outflow, and they will reduce the aqueous production and also lowers the episcleral venous pressure. And additionally, they will help in regulating the wound healing and fibrogenesis especially after post trabeculectomy, and we can safely use this property in post keratoplasty patients as well. And it also increases the nitric oxide release on the optic nerve head, thus providing the neuroprotection. So if I am talking about ripasudil as an agent, it's the first ROC kinase inhibitor. It came in the industry, and it is a selective ROC inhibitor. It's available as a dosage of 0.4% solution, which can administered as bi-daily dose, and it has a reduction of 3.7 millimeter of mercury from the baseline, and it is available as fixed drug combination along with the prostaglandin analogs and beta blockers. The second agent is netasudil. It came in the field in 2017. It has additional inhibitor action on the norepinephrine transporters, and it is available as 0.02% solution, and it is administered in once daily dose. Other fixed drug combination available along with latanoprost it is named as rocklatan. The main side effects are conjunctival hyperemia. Because of its nitric oxide production, it will cause the vasodilatation, and the other is reticular corneal edema. Then these are the trials related to ROC kinase inhibitor, and ROCKET 1 and ROCKET 2 compared the effect of netasudil with the timolol, and it is they have proven that it is equally efficacious, and it is non-inferior to timolol. And Mercury 1 and 2 is the comparison of netasudil latanoprost combination with the netasudil versus latanoprost alone, and the fixed combination has proven a higher IOP reduction compared to the monotherapy. The safety in pregnancy and lactating women is not known, and it is under trial. Then coming to the investigational drugs like adenosine receptor agonist, adenosine increases the activation of these adenosine receptors increases the outflow facility. So one example is trabedonosone. It is A1 adenosine receptor agonist and phase 3 clinical trial. The second one is ceftoprost. It is a prostaglandin analog which acts on the EP3 and F receptors. According to Angel study is a phase 2b randomized control study. It concluded that it has a comparable IOP lowering effect and safety like latanoprost. Then big potassium and calcium ionic channel modulators. It increases the level of nitric oxide. Example is latanoprostene bunod. It is a nitric oxide donor as well as a prostaglandin analog. Its active components will increase the uvascular outflow as well as the trabecular outflow, and it is available in a dosage of 0.024% once daily dose. These are the trials related to latanoprostene bunod and Voyager study, Constellation, Apollo, Lunar, and Jupiter study. They have proven that it is non-inferior to timolol. Then coming to local calcium channel blockers, where verapamil can be used, but the use is limited because of the systemic side effects. Then coming to prostaglandin, prostanoid receptor agonist, EP2 and EP3 receptor on its activation increases the uvascular outflow as well as the trabecular meshwork outflow. Example is omidipag, which is introduced in 2018. It is an EP2 agonist. Then coming to small interference RNA, these are a double stranded small interfering RNA which causes the beta 2 adrenergic receptor blockade and thus decreases the aqueous production. But whatever we are seeing with the commercial beta 2 blockers, the systemic side effects are not there, so directly we can use it. The example is bamosiran. Then CRISPR-Cas9 RNA, it is it will cause the disruption of the aquaporin 1, because aquaporin 1 is a protein that is involved in the aqueous production. So this CRISPR-Cas9 RNA will interfere with this aquaporin and thus decreases the aqueous production. And gene therapy, adenoviral gene therapy is also under consideration in this. Then coming to cannabinoids, CB1 and CB2 receptors are present in almost all the ocular structures. This activated component of the cannabinoids like THC, it has a IOP lowering effect. It will act on CB1 and CB2 receptors, but the problem is it has a controversial use because as we know, it has side effects like dizziness, confusion, sleepiness and all, but it has additional neuroprotective effect as well. These are the routes like oral, intravenous and inhalation and topical formulations are there. Then other cellular cytotoxic modulators are there like ethacronylic acid and latanoglins, and cellular signaling pathways molecules are there, olmesartan and lometricin. Then latanoglin derivatives are there, macrolides, and inhibit actin polymerization and which increase the trabecular outflow. Then other drugs are under consideration are angiotensin 2 receptor agonist, 5-HT2 agonist, and anacotive acetate. Then alternative drug delivery systems. Why we need alternative drug delivery systems? Because it increases the drug retention, less side effects, increase penetration, and decrease frequency of administration and better patient compliance. First is Ocusat. It's a polymeric membrane coated delivery system of pilocarpine, but because of its disadvantage, it is withdrawn from the field, and these are soft contact lenses. They will elute the drug continuously. 1% pilocarpine is included in the lens will be equal to the 8% topical eye drop. Then this is Durista, or it is a bimatoprost implant. It is a sustained release biodegradable intracameral implant available in the dose of 10 and 15 microgram. It is FDA approved in 2020, and it elutes the drug for 3 to 4 months. The only side effect is corneal endothelial cell density will be decreased. This is nanotechnology. Actually, it bypasses the biological barriers, so it directly elutes the drug at the target site. So these are the examples like subconjunctival injection of dorzolamide, supraciliary injection of brimonidine, and intravitreal injections of brimonidine, travoprost, brimatoprost, and lead macrophages. And Timoptix SC is a newer timolol drug. Actually, once we instill it, once it comes in contact with the tear film, it will become a gel form. So sustained release will be there. This is beam ring. It is a bimatoprost ring, and it elutes the drug for around 6 months, and we can place it in the fornix as we can see in this picture. Then this is ocular punctum plug. It is a travoprost punctum plug which is used as a punctum plug, and it can deliver the drug over 90 days. It has a fluorescent property, so we can aid in visualization, and radiologically we can see that. Then this is iDose. It is a sustained release intracameral travoprost which can be implanted intracamerally. Then neuroprotection, actually, it is already explained by Dr. Soumya. So that's all. Thank you.
Thank you, Kavya, for the wonderful talk. So, any questions?
So I have a question to Kavya. So this ROC inhibitors which you are using, as common side effects is this transient hyperemia, which occur after application of the medicine. So what are the measures you do to prevent it? Because often patients complain of this hyperemia a lot. So what do you add with it? Do you add some extra medicines like a lubricant, or
Actually, the cause of hyperemia is due to the vasodilatation because it will release the nitric oxide locally. So, by using lubricant alone itself, it will not reduce the congestion. Actually, before giving the drug, we should counsel the patient that once we start this drug, the patient will have a congestion. So, don't get afraid like that, because like other conventional drugs, it has the problems like severe dry eye and all. But actually now we prefer this drug as a last choice. First we give the first our drug of choice like a prostaglandin and timolol. Then if the patient is having some other contraindication, then only we will be considering these drugs like ROH inhibitors. So we should explain the patient like it will be a side effect, but nothing will be there. And like as we give lubricants along with other drugs, we can also prescribe along with this, but the lubricant use itself will not relieve the congestion. Thank you.
I have one question to Bindu madam. When you give latanoprost or prostaglandin timolol combination, which is the timing you usually advise, morning or evening? But sometimes the patient will be using latanoprost, then we will be adding timolol. So patient will tell like it's better for me to use in night because I have already been using in night. So that kind of situations happen.
I prefer in the morning, and I advise them when you prescribe a new medication, you always give a new timing. So I usually tell them it's only in the morning. I don't know if anyone has a different opinion.
Continue to give it at night itself. The only hiccup when you give it night as a combination is beta blocker. So just make sure that the no antihypertensives are happening beta blocker at night, because that will end up in a nocturnal hypotension. So that's the only worry which you should have. Otherwise, studies have proven both are effective, but this is for me like it's like a convenient dosing when they say at night.
Okay, so we completed a bit earlier. Can we take a group photo?